I want to start with a woman named Margaret, 72 years old, retired school teacher, grandmother of four. She came into my office, not because she felt sick. She felt wonderful, actually. She came in because her daughter had been nagging her for months to get a checkup. Margaret laughed about it during the visit. She said, "I keep telling her I feel better now than I did at 50. Her daytime blood pressure, 122/76. Textbook perfect. I sent her home with a 24-hour monitor, just as a precaution, more to ease the daughter's mind than anything else. When she came back 2 days later and I looked at the overnight readings, I had to look twice. At 2 in the morning, her blood pressure was 171/104. She was asleep. She felt nothing. She remembered nothing. She had absolutely no idea that every single night while she was dreaming about her grandchildren, her cardiovascular system was quietly under siege. That moment, that conversation with Margaret, is why I made this video today. Because here is the thing that most people, and honestly, even many physicians, don't fully appreciate. The blood pressure reading you get at your doctor's office, the one that takes about 30 seconds, the one your entire treatment plan is often built around, that number only tells a fraction of the story. A fraction. Your doctor sees you for maybe 15 minutes. You are nervous. Maybe you rushed to get there. Maybe you found parking difficult. Maybe you had coffee that morning. That reading captures one tiny moment out of the 86,400 seconds in your entire day. And the most important seconds, the ones where your heart is working its hardest without any supervision at all, are the ones you spend sleeping. That's where the real story is being written. And for millions of people over 60, it is not a good story. Let me explain what is supposed to happen at night. Because understanding this changes everything. Under normal, healthy conditions, when you fall asleep, your body does something extraordinary. Your blood pressure drops. It drops by about 10 to 20% compared to your daytime levels. Every night, reliably, like clockwork. Cardiologists call this the dipping pattern. And it is not just a nice thing for your heart. It is absolutely essential. During those nighttime hours when pressure drops, your heart repairs microscopic damage from the day. Your arteries recover their flexibility. Your kidneys process waste products and recalibrate fluid balance. Your brain clears out metabolic debris through a system we only recently discovered, called the glymphatic system. Every single one of these processes depends on that pressure drop happening on schedule, every night, without fail. It is your body's maintenance window. Think of it like a factory that runs all day and needs those quiet overnight hours to clean the machinery, replace worn parts, and get ready for the next day. If the machines never shut down, they wear out faster. That is exactly what happens to your heart and blood vessels when the nighttime dip stops occurring. And here is what changes after 60 that most people are never told. Your arteries naturally stiffen with age. The walls of your blood vessels lose some of their elasticity. This is not a disease, it is biology. But it changes how your whole cardiovascular system responds to the signals that used to trigger that nighttime drop. The autonomic nervous system, the part of your nervous system that runs things you don't consciously control like heart rate and blood pressure, starts losing some of its precision after 60. The signals become less reliable, less consistent. And for a very significant number of people in that age group, the nighttime dip simply stops happening. The pressure stays elevated all night. Or in some cases, it actually rises higher than daytime levels. And the person sleeping in that bed has no idea. They wake up the next morning, they feel a little tired, maybe a little foggy, and they think, well, I just didn't sleep that well. They don't connect it to what their cardiovascular system was actually doing during those 8 hours. I had another patient, a man named Gerald, 68 years old, retired electrician. He came in complaining about fatigue. Not dramatic fatigue, just a kind of low-level tiredness that had been building for about a year. He figured it was just getting older. His wife thought he was maybe a little depressed. His daytime blood pressure was fine. His labs were mostly normal. But something about the picture didn't sit right with me, so I ordered the 24-hour monitor. Gerald was a non-dipper. Not only was his pressure not dropping at night, it was running higher at 2 in the morning than it was at 2 in the afternoon. We adjusted his treatment, had a serious conversation about a few habits I'll get into in a moment, and within 3 months his fatigue was dramatically better. His wife told me she felt like she got her husband back. That tiredness he had been carrying for a year wasn't depression, and it wasn't just aging. It was his heart working harder than it should have been, every single night, and his body paying the price every single morning. We have a name for people like Gerald, like Margaret. We call them non-dippers, and I want you to understand how common this is because most people assume it must be rare. It is not rare at all. More than 50% of adults over 65 are non-dippers. More than half. That is the majority. Think about that for a moment. More than half the people in that age group are carrying a cardiovascular risk that their routine morning blood pressure check will never, ever detect. And non-dippers don't just have a slightly elevated risk. They carry cardiovascular mortality risk 3 times higher than people who dip normally, even when their daytime numbers are completely identical. Same reading in the office, same medication, same diet, 3 times the risk, purely based on what happens during sleep. That is not a minor clinical footnote. That is the central issue, and it is happening silently in millions of homes every single night. There is an even more alarming pattern called reverse dipping, where blood pressure actually rises during sleep, higher at night than during the day. For reverse dippers, stroke risk increases by a factor of 4 or 5, and they feel completely fine at a routine office visit. Completely fine. That is what makes this so difficult, and why I feel so strongly about bringing this information directly to you, rather than waiting for it to filter down through busy clinic visits. The system, as it currently runs, is not designed to catch this. You have to know to ask for it. And today, that is exactly what I want to give you, the knowledge to walk into your next appointment prepared. Before I talk about solutions, I need to spend a few minutes on things that might already be in your home, making your nighttime blood pressure worse without you ever suspecting them. Because this part genuinely surprises people every time. The first one is licorice root. I know it sounds so innocent. It is an herbal tea. It is natural. It is warm and soothing before bed. Many people who care a great deal about their health drink it specifically because it seems like a gentle, wholesome choice. But licorice root contains a compound called glycyrrhizin that blocks an enzyme in your kidneys. When that enzyme is blocked, cortisol, your stress hormone, builds up in your bloodstream overnight. Elevated cortisol means elevated blood pressure. You don't feel it surging. You just wake up exhausted and never connect the two. Here is the tricky part. Licorice root doesn't always appear on labels as licorice root. It hides as sweet root, glycyrrhiza, or simply inside the phrase natural flavoring in herbal blends. Go to your tea cabinet tonight and read the labels. Every single one of them. The second thing is evening alcohol. And I want to be thoughtful here because I know this is a sensitive topic, and I am not here to lecture anyone about their choices. But the physiology is what it is, and you deserve to know it. The initial effect of alcohol does lower blood pressure. That part is real, and many people feel it as a kind of relaxation. But 3 to 4 hours later, right in the middle of deep sleep, your sympathetic nervous system overcorrects. There is a rebound spike, cortisol surges. Blood pressure can reach its highest point of the entire 24-hour cycle at 3 in the morning, precisely when there is no one awake to notice, no one checking, no monitoring happening at all. I had a patient, a lovely woman named Dorothy, 70 years old, who had 1 glass of red wine every evening before bed. She had read it was good for the heart, and in some contexts there is research supporting moderate wine consumption. But her overnight monitor showed pressure spikes in the early morning hours that were alarming, and they correlated exactly with her evening routine. When she shifted her wine to earlier in the evening, with dinner rather than right before sleep, her overnight numbers improved noticeably within 2 weeks. Same amount, same wine, just different timing. That is how specific this is. The third hidden factor is grapefruit juice, specifically when you are taking certain blood pressure medications. Grapefruit blocks a liver enzyme responsible for breaking down drugs like amlodipine and certain other calcium channel blockers. When that enzyme is blocked, the medication accumulates in your system at a higher level than intended. What was designed to be a gradual, controlled effect becomes something much less predictable. And because this unpredictability happens at night, when no one is watching and you are not in a position to respond, it creates a kind of pharmaceutical wild card in your overnight cardiovascular picture. If you are on any calcium channel blocker, ask your pharmacist specifically about grapefruit. This is not theoretical. It is a well-documented interaction that affects a significant number of people who have no idea it is happening. Now let's talk about what you can actually do. Starting with the thing most people never consider, and yet the evidence for it is some of the strongest in modern cardiovascular medicine. Medication timing. This is not about changing your medications, not about adding new ones, not about increasing doses. It is simply about when during the day you take what you are already taking. Most blood pressure medications are taken in the morning. That is the convention, the habit, the way it has been done for decades. But think about the timing for a moment. Most antihypertensives reach their peak protective effect within a few hours of being taken and then gradually wear off throughout the day. If you take your pill at 7 in the morning, by midnight, by the time your cardiovascular system is entering its most vulnerable hours, its protective effect has substantially diminished. You are running on reduced coverage precisely when you need it most. A landmark study called the Hygia chronotherapy trial looked at this question directly. 20,000 patients, 6 years of follow-up, one of the largest cardiovascular trials ever conducted on this specific question. Half the patients took their blood pressure medications in the morning as usual. The other half took the same medications at bedtime. Everything else was equal. Same drugs, same doses, same patients. The bedtime group showed nearly 50% lower rates of heart attack, stroke, and cardiovascular death. Nearly 50%. Not from a new drug, not from an expensive intervention, not from a complicated lifestyle overhaul. From changing the time of day a pill was taken. The implications of that finding are enormous, and most patients have never heard of it. Now, and I want to be very direct about this, do not change your medication schedule on your own. Some medications, particularly diuretics, genuinely should not be taken at bedtime for practical and physiological reasons. This requires a conversation with your doctor, a review of your specific medications, and your specific history, but the conversation is absolutely worth having. Write it down. Ask at your next appointment. One question. Given what I've read about nighttime blood pressure and medication timing, Is bedtime dosing something we should discuss for my situation? That question could change the entire picture. I want to tell you about the drink now, because that is what brought many of you here, and the evidence behind it is genuinely worth understanding. Not just the what, but the why. Because when you understand the mechanism, you will trust it more and use it more consistently. The drink is hibiscus tea, specifically tea brewed from the dried flowers of Hibiscus sabdariffa. And before you skip past this because it sounds too simple, too ordinary, let me walk you through what the science actually shows, because it is not ordinary at all. Hibiscus flowers contain a family of compounds called anthocyanins. These are the same pigments that give blueberries their deep blue color, pomegranates their rich red, and red cabbage its purple hue. They are powerful antioxidants, meaning they neutralize free radicals, the unstable molecules that damage arterial walls and contribute directly to the kind of arterial stiffness and oxidize cholesterol that drive nighttime hypertension. But hibiscus does something more specific than general antioxidant activity. It inhibits an enzyme called angiotensin converting enzyme, or ACE. If that sounds familiar, it is because ACE inhibitors are one of the most commonly prescribed classes of blood pressure medication. Hibiscus works on the same pathway. That is not a metaphor or a loose analogy. It is an actual pharmacological mechanism studied in laboratories, replicated across multiple independent research groups, and demonstrated in clinical trials. Multiple controlled trials have shown consistent reductions in systolic blood pressure of 8 to 14 millimeters of mercury in patients with mild to moderate hypertension who drank hibiscus tea daily. For reference, many blood pressure medications produce reductions in that same range. 8 to 14 points is clinically meaningful. That is not a rounding error. That is real cardiovascular protection. But here is where most people go wrong with hibiscus, and it is the reason many people try it, feel nothing, and conclude it doesn't work. The preparation matters enormously. I cannot stress this enough. Weak hibiscus tea has minimal therapeutic effect. A single tea bag steeped for 3 minutes in hot water, and the color comes out pale pink. That is not what the studies used. That version will do very little for your blood pressure. Here is what actually works. You want 10 grams of dried hibiscus flowers, not a commercial tea bag, not a blend with hibiscus listed as one of 12 ingredients. Actual dried hibiscus flowers, which are widely available in health food stores and many international grocery stores. You want your water at about 90 degrees Celsius, just below a full boil. You steep it for 10 to 15 minutes. Not 5, not 7, 10 to 15. The extraction time is critical for the active anthocyanins to fully release from the plant material. When it is properly brewed, the color should be deep, deep burgundy, almost like a dark red wine. If your cup looks pale pink, it needs significantly more steeping time. The clinical literature studied 3 cups per day, but the most important cup, the one with the greatest impact on what happens to your pressure overnight, is the cup you drink in the evening, 1 to 2 hours before sleep. That timing window is when it has its most meaningful effect on your overnight cardiovascular profile. I had a patient named Robert, 74 years old, former accountant, whose wife had actually started making hibiscus tea for herself for unrelated reasons. He started drinking it with her in the evenings, mainly for company. 3 months later, he came in for a routine follow-up, and his overnight monitor readings had improved noticeably. He had not changed his medications. He had not dramatically overhauled his diet. He had added 1 cup of properly brewed hibiscus tea every evening. Now, I am not suggesting hibiscus tea alone is a treatment for high blood pressure, and I would never suggest replacing prescribed medication with a beverage. But as part of a comprehensive approach, alongside appropriate medication, alongside the conversation about timing, alongside eliminating the hidden nighttime factors, it is a genuinely meaningful piece of the picture with real evidence behind it. One important note: if you are already on blood pressure medication, tell your doctor before starting hibiscus tea regularly. The effects can be additive. That is not a warning to avoid it. It is simply important information for your doctor to have, so your overall management stays coordinated. Now, how do you actually know what your nighttime blood pressure is doing? Because everything I have described, the non-dipping, the nighttime surges, the hidden risk, is invisible without the right testing. There is a specific test designed for exactly this. It is called ABPM, ambulatory blood pressure monitoring. You wear a small cuff for 24 hours, going about your completely normal daily routine. The cuff takes readings automatically every 30 minutes throughout the day and night. You sleep with it. You wake up with it. You live with it for one day. When you return it, your doctor has a complete blood pressure profile, including every overnight reading, the full 8-hour picture that a 30-second office measurement will never provide. This is the gold standard for identifying non-dipping patterns, and the majority of people over 65 have never worn one. Not because it is expensive or hard to access. It is neither. But because doctors typically don't order it unless there is an obvious clinical reason, and most patients don't know to ask for it by name, ask for it by name at your next appointment. ABPM. Write it down right now. The second test is urine microalbumin. This measures a tiny protein called albumin that leaks into the urine when the kidneys are under sustained pressure. Microalbumin is one of the earliest detectable signs of kidney damage from hypertension. It appears years before kidney function shows any visible decline on standard lab tests. It is a warning signal that there is still time to act. It is the kind of finding that, caught early, changes the entire clinical picture and opens up options that are no longer available once damage becomes permanent. Most routine checkups do not include it unless you ask. The third test is oxidized LDL. You know LDL as the so-called bad cholesterol, but oxidized LDL is specifically what happens when that cholesterol is damaged by free radicals, essentially rusted cholesterol. It is far more destructive to arterial walls than regular LDL, and it is a direct marker of the kind of arterial wall damage that sustained nighttime hypertension accelerates. Standard cholesterol panels do not measure it. It requires a specific test that most labs can run without issue. Those three tests together, ABPM, urine microalbumin, and oxidized LDL, give a picture of cardiovascular health that no standard checkup in the world currently provides. Affordable, available, and almost never ordered unless you walk in prepared and ask for them specifically. Write them down. ABPM, microalbumin, oxidized LDL. Those three words are your entire agenda for your next appointment. Let me bring everything together into something concrete, because I want you leaving this video with a plan, not just information. Tonight, not next week. Tonight, go to your tea cabinet and read every label, every single one. Look for licorice root, glycyrrhiza, sweet root, or natural flavoring in anything you drink in the evening. If you find it, that tea moves to the morning or out of the house. That is step 1, and it takes 5 minutes. Step 2 is an honest look at your evening alcohol habits. Not judgmental, just honest. Is it happening regularly? Is it happening close to bedtime? If so, consider whether it can be shifted earlier in the evening. closer to dinner time rather than the hour before sleep. The chemistry of what happens at 3 in the morning is real regardless of whether you can feel it. Step 3 is to get some dried hibiscus flowers. Brew them properly. 10 grams, 90 degrees, 10 to 15 minutes, deep burgundy color, and make that your new evening ritual 1 to 2 hours before sleep. Step 4. Write down ABPM, microalbumin, oxidized LDL, on a piece of paper and fold it into your wallet next to your insurance card. Step 5. Write down one question for your doctor. Given what I've learned about nighttime blood pressure and medication timing, is bedtime dosing worth discussing for my situation? 5 steps. Some of them take minutes. All of them have the potential to materially change your cardiovascular picture. I want to close with something I think about often, something that drives everything I do in this work. I have been in cardiac surgery long enough to have stood at many bedsides after events that changed lives irreversibly. Strokes, major heart attacks, the calls made in the middle of the night. And in a significant number of those cases, especially in patients over 60, when I look back at the history, the warning signs were there, not visible in the standard office readings, but present in data that was never collected, in nighttime patterns that were never measured, in slowly rising microalbumin that was never checked, in arterial stiffness, quietly building for years with no one tracking it. In many of those cases, not all medicine is humbling, and not everything is preventable, but in many of those cases, a different conversation at an earlier appointment could have changed the trajectory. Margaret, the retired teacher I told you about at the beginning, she is doing well. We addressed her nighttime pattern, adjusted her management, had a long conversation about the things you and I have discussed today. She calls the office every few months to check in. She told me recently that her daughter has stopped nagging her, because now Margaret is the one bringing the questions to the appointments. She comes in with a list. She knows what to ask for. She understands what her numbers mean in a way she never did before. That shift from passive to informed, from reactive to prepared, is the whole point of everything I do in these videos. You now have what Margaret has. You know about nighttime blood pressure and why it matters more than your daytime reading alone. You know about non-dipping and what the risk actually looks like. You know what to remove from your evening routine and what to add. You know the 3 tests that paint the true picture. You know the conversation to have about medication timing. You know how to brew hibiscus tea the right way and when to drink it. Walk into your next appointment with that knowledge. Bring your list. Ask your questions. Your doctor cannot give you information you never asked for, but they can absolutely give you better care once you do. That is the chain that matters. Better information, better conversations, better outcomes. You have taken the first step today. The next step is yours to take. I will see you in the next video, and until then, please take exceptional care of yourself and of the people you love. And as always, I want to be completely transparent about one important thing. Everything shared in this video is for educational purposes. It reflects current research and my clinical experience, but it is general information, not personal medical advice. Your situation is unique. Your medical history is specific. Your medications were chosen for reasons that are individual to you. Please talk to your own physician before changing anything, before adjusting when you take your medication, before adding hibiscus tea regularly, before making any significant change to your routine. That conversation is not a formality. It is the most important step of all. The goal of this video is to make that conversation better, more informed, and more useful for both of you. Take care of your heart. It has been working for you every hour of every night, without pause, without rest, without a single complaint, for every year of your life. The least we can do is pay attention,